Okay, so let us start with today's webinar session on bone grafts. Now, our speaker for today's session is Dr. Arun Gomes sir, and moderator is Dr. Surekha Rathod madam. I welcome you all. I welcome all the participants. Good morning. Now, Dr. Surekha Rathod madam is working as a professor in Department of Periodontics, VSPM Dental College and Research Center, Nagpur. Madam did her BDS and MDS from Government Dental College and Hospital, Aurangabad. Madam has also done BA in Psychology, Bachelor of Journalism, and Bachelor of Journalism. And Madam has over 200 national and international publications to her credit. I welcome you, ma'am.
Thank you, Dhaval. A very good morning to the speaker, the host, and the participants. I take the opportunity to welcome you all to the Oral Hygiene Days webinar series conducted by VSPM DCRC. We have attended the previous webinars and witnessed the glory of the speakers, which made us updated and connected with the recent advances and also help our postgraduates in their academics. I also want to pay my heartfelt gratitude towards Dr. Abhay Kolte sir, HOD, Department of Periodontology, VSPM, Dental College and Research Center, Nagpur, for giving us sky to paint the rainbow. It is a beautiful journey and it has been always the spine of victorious phenomena. I also want to greet and welcome the speaker for today's webinar, Professor Dr. Aaron Gomes, a BDS alumni of the Goa Dental College and MDS alumni of Government Dental College and Hospital, Nagpur. He joined academics at the PMNM Dental College, Bagalkot in 1995. After academic stints at AIM Dental College, Bijapur, and SDM Dental College, Dharwad. He is presently heading the Department of Periodontology and Oral Implantology at Uttaranchal Dental and Medical Research Institute, Dehradun. He has conducted CD programs extensively across the country and has national and international publications. I hand over the virtual platform to the Dr. Aaron Gomes, sir.
Yes, thank you, moderator, Madam Dr. Surekha Rathod, for those glowing words about me. At the outset, I would like to wish you all a very, very good morning on this bright Monday. I hope there are no Monday blues. But and special gratitude to the Dean of the college and VSPM Dental College, the Vice Dean, Dr. Shenoy. We have worked together in Nagpur. And of course, my dear friend, Dr. Abhay Kolte and his whole team, especially Dr. Modi. So we start with the presentation today. A very good morning to all of you all, my seniors, my colleagues, and my fledgling periodontists all around India. And we seem to be having some problem. Just a minute. And I bring you greetings from Dehradun. This is a nice picturesque space just outside Dehradun. And today we are going to talk about bone grafts, the current milieu in periodontal regeneration. What we are basically going to talk about is bone replacement materials. Why I'm using the word bone replacement materials? Because you must understand you're placing the bone graft after there is some sort of loss of the periodontium, mainly because of the influence of periodontal disease, which is arising because of the contents of the plaque biofilm. And so we are using bone replacement materials to replace the bone that has been previously lost and regain a sort of a bone fill and preferably maybe new attachment. So it's we may also be talking about the use of bone replacement materials or bone replacement grafts or substitutes for implant site development, as well as the bone which has been lost around implants because of the result of peri-implantitis. I guess all of you all have received this form for the pre-webinar questionnaire, and with that we can continue. And we seem to be having a small problem with my, why am I having a problem? This is actually a situation wherein it's like Intel inside and an idiot outside, I guess. Let me just rectify my screen and I'll start again. Yeah, that's a common adage. We have these Intel computers, so it's usually an intelligent system inside, and the person sitting outside knows so little, right? Yeah, I think I've got my system back. Yeah, I'll just start back again, please. I'm sorry. Dhaval, can you see now?
Yes, sir. It's clear, sir.
Yes, so we were on the situation of the bone grafts, the current milieu and periodontal regeneration. And I'm just not able to go ahead. What's happening? Yes, I bring you greetings from the Department of Periodontology and Oral Implantology at UDMRI Dehradun. And the disclaimer out here is that the institution, neither do the agonizers nor the author, are endorsing any of the products which we are showing in this presentation. As the moderator madam has said, I did my graduation from the Goa Dental College, a picturesque college in Bambolim, Goa. And oh my God. My slide is just not refusing to move ahead. Dhaval, I'm so sorry.
No, it's okay, sir.
Aaron, you can try. If it works, it's okay. If it doesn't work, we can reschedule it. Maybe after an hour or so.
No, no. Yes, if I can continue, and then my post-graduation was done at the Government Dental College and Hospital at Nagpur. And at this place, I got my blessings and my teachings from my Guruji, Professor Dr. R.K.L. Tiwar sir. So I would like to dedicate this webinar to my Guruji. Because of him, it's what I am today, and all because of his blessings and his teachings. And along with the dedication to him, I would like to dedicate this presentation to all the other stalwarts of periodontology, some living, some dead in India, as well as abroad, like Shankwalkar sir, Jinwala madam, the late Lalit Guglani sir, Ingrid De Silva madam, KP Kamath sir in Goa, Kale sir, then abroad SN Bhaskar and Ashok Patel. And this is me trying to sit comfortably, but obviously I cannot with my Guruji, because of course my place is only in his shadow. So all that I am, I owe to my Guruji, Dr. R.K.L. Tiwar sir, and sir, I'm dedicating my presentation to you. And under his guidance, I did an animal study wherein I studied the histologic and clinical study of the response of the tissue to hydroxyapatite, which was placed in iatrogenically prepared defects in the New Zealand white rabbits. And this was studied up to a period of 12 weeks, including a histological study. That's all about me, yours truly, Aaron Gomes. But coming back to the topic per se, if you look at the American Academy of Periodontology's position paper in 2011, the comprehensive periodontal therapy, it starts with the patient education. And after that, we have the management of the periodontal systemic interrelationship, the removal of supra and subgingival bacterial plaque biofilm, chemotherapeutic agents for the same, resective procedures also probably to help this therapy. And number 6 is periodontal regenerative procedures, including bone replacement grafts, as well as the use of biologics, root modification, guided tissue regeneration, and a combination of that so as to try to attain new attachment. So what's this regeneration that we're talking about? The major challenges are that the regeneration of the gingival connective tissue destroyed by inflammation, the formation of new cementum, and the restoration of the bone which we have lost because of the periodontal disease, and most importantly, the new attachment of new connective tissue fibers to a surface which was previously diseased. So the ultimate goal is the restoration of the structure and function of diseased periodontal tissues as much as possible to the level before it got diseased. If you look at the glossary of periodontal terms as given in the 4th edition of 2001 as given by the American Academy of Periodontology, the new attachment is the union of connective tissue or epithelium with a root surface that has been previously deprived of its original attachment apparatus by the disease process mostly. So a new attachment, we want an epithelial adhesion and or a connective tissue attachment, which may include even new cementum. While if you look at repair, it does not fully restore the architecture or the function of that part. So when we have got our plaque biofilm and calculus aggregations and we have got a deep periodontal pocket, what we will try to do is remove the pocket lining. Once we remove the pocket lining and we expect this defect site to heal, the first thing that will happen, there'll be a rapid downgrowth of the epithelial cells from the gingival epithelium. So these epithelial cells are going to populate this defect site much faster than the cells from the gingival connective tissue, much faster than the cells from the periodontal bone, and definitely faster than the multipotent pluripotential cells which are having the potential to form new biofibroblasts and new osteoblasts which arise from the periodontal ligament. So our main culprit is out here, the gingival epithelial cells and the gingival connective tissue cells. We would like to prevent that. We can prevent that by placing some sort of material out here such that these cells do not get that area to, so sort of you block that parking space well in advance so that you can come and park your car. So if I can block this area, this will be able to repopulate here. I will get new bone. I may get ankylosis though, or best still, I can guide or allow the pluripotential cells from the periodontal ligament to populate this area by placing a membrane here. So my membrane will not allow, or my placement of some bone replacement material over here will not allow the formation of the long junctional epithelium, which would have happened if I had done a simple open flap debridement. This long junctional epithelium, as you know, has been described by Ketan et al. And given a lot of research by the Listgarten. The problem in this, though you get a tight cuff, the attachment is still at an apical level. This is what I want. I want the attachment at a much coronal level. I do not want a long junctional epithelium. I would like to get new bone. I would like to get new periodontal ligament and probably even cementogenesis. So now the whole situation is that what is bone fill? Again, the glossary of the periodontal terms have defined the bone fill as a clinical restoration of bone tissue in a treated periodontal defect, though it does not necessarily address the histological nature of the new attachment. I think I've got stuck again. So the whole endeavor is that when I have my bone defect here, if I can place this bone graft material, it will prevent this epithelial cells from coming down, and therefore I can get new bone. The same principle I can use also in a situation when I want implant site development. I've got too thin a ridge, and therefore I cannot place my implant. So if I can place my bone replacement material here, probably place a membrane also on the top, I will be able to build up my ridge and therefore place an implant. So our techniques for bone defect augmentation can be used in ridge splitting, can be used in sinus lift augmentation, immediate implants, use of autografts, guided bone, allo block, but mainly we'll be talking of only these three situations. So what are the aims of biological bone reconstruction? We would like to get sufficient bone volume, a vital bone matrix, a safe therapy, and a low complication rate with a high patient satisfaction involving minimum trauma. But, so what does the glossary of periodontal terms tell us about the attachment apparatus? It talks about, of course, the alveolar bone. It talks about the periodontal ligament and cementum. But is this only enough to achieve predictable bone regeneration? No, we need also a proper revascularization of our bone defect, as well as a proper soft tissue coverage. Do not forget our Melcher's theory that the defect site is repopulated by epithelial cells, which we want to prevent, by connective tissue cells from the gingiva, which you would like to not allow in that area, by progenitor cells from the bone per se, as well as progenitor cells from the periodontal ligament. So Is there something about a bone since he's the main hero of our show? Let's talk about the bone basics. We basically will have three parts for our understanding. I'm breaking it up macroscopically into three parts. The periosteum. I usually tend to call the periosteum as the fifth part of the periodontium because my Guruji always told me, handle that periosteum with care. If the amount of time that you leave the periosteum away from the bone when you reflect a mucoperiosteal flap is going to be the amount of the swelling that you're going to get post-surgically, the amount of inflammatory process that is going to be there. Why? Because the periosteum is the guy who is the plexi shield around the bone. He's the guy who is supplying the blood to the outer portion of the bone. And that outer portion of the bone is my cortical bone. Yes, it's very thick. Yes, it's very tough. Yes, it's very dense. Yes, it can bear a lot of weight and load. But it has got minimal blood supply through a Hevesian system, a supply through the Walkman canals, and it has got very less amount of viable cells. On the contrary, we have the cancellous bone out here, and the cancellous bone is quite porous because of the medullary cavities, as well as it has got high amount of these cells. It has got high amount of osteoblasts and osteocytes, and therefore, as we can see later on, this bone is going to help us the best when it comes to regeneration. So basically, we are talking about bone cells, bone cells, bone cells. We are talking about osteoblast, osteoclast, osteocyte, the progenitor cells, and the inflammatory cells. So when we are talking about the progenitor cells, they're basically the multipotent stromal cells present in the bone marrow, which are capable of differentiation into osteoblasts, chondrocytes, and adipocytes, forming those respective tissues. During healing, the osteoblast is the one which is going to form the collagen, the callus formation, as well as the osteoid tissue. What's happening? Every time I'm doing the admit, I'm getting problems. So when we talk about the next one is our osteoblasts, and they are primarily responsible for the secretion of the osteoid tissue, and they produced by the alkaline phosphatase. They are responsible for the bone mineralization as well as the secretion of collagen type 1, osteopontin, bone siloprotein, and osteocalcine. What are the osteocytes? They are the osteoblasts which are embedded into the bone and transformed into osteocytes. They occupy spaces like the lacuna. They are said to act as mechanosensors to control the adaptive responses to the mechanical loading and therefore the bone remodeling. The osteoclast, their main role is the bone resorption. They create an acid environment by the acid phosphatase, and they therefore have an acid dissolution of the mineralized matrix and how Schiff's lacunae are formed. Of course, you'll have the inflammatory cells like the neutrophils, monocytes, and lymphocytes, which are responsible for the ingestion of the foreign particles, bacteria, and dead cells. So what happens whenever there is a bone injury? Whenever you do a bone open flap debridement, you're actually injuring the bone as well, or an actual fracture of the bone. The first step that will take place is the hemostasis. This will happen in the initial 5 to 10 minutes, wherein there is vasoconstriction and the bleeding slows down. The platelets are released and the fibrin leaks into the injured vessels, and this results into a clot, as well as, don't forget, the platelets will then release the growth factors such as the platelet-derived growth factors, and the cytokines. Of course, this is part of the next few phases. The next phase is the inflammatory phase, which is the granulation phase. It will last for 4 to 6 days. There will be presence of your regular signs of inflammation, and this initially is predominantly filled with neutrophils, later on by macrophages. Macrophages, remember, are critical in the repair process because both of them, they will release chemoattractants and growth factors needed for tissue repair, but the macrophages start releasing the chemoattractants for the fibroblast. However, they will also release chemoattractants which will result in the progenitor cells of the osteoclasts. Osteoclast, remember, is for resorption, the osteoclasts to form. But then bone remodeling is important for us. So now we get fibroblast and endothelial cells, as well as, don't forget, there is a lot amount of the transforming growth factor, bone morphogenetic protein, which is helping the proliferation and differentiation of these osteoprogenitor cells into the cells of the osteogenic linkage or the connective tissue formation linkage. So therefore, you have got a lot of collagen, which will form granulation tissue, and therefore new extracellular matrix and the blood vessels. We now slowly start moving into the bone formation stage, which will last about 6 to 21 months. And so initially there is fibroblast formation, which will deposit collagen. And then there is intramembranous or endochondrial deposition of bone by the osteoblast. Also, don't forget, there is bone formation by because of the triggering of the osteoblast progenitors, which will form osteoblast, which will form new bone. But on the other side, don't forget, the osteoclast precursors are getting activated. You get osteoclast formation, and so bone remodeling, that is, there is classes of bone here, formation of bone here, bone remodeling taking place. So you'll get bone remodeling, which is on one side formation, and there is on the other side the resorption of bone. This is very, very important because Craig M. Mish, has given in 2012 the concept of creeping substitution, wherein there is slow resorption of the donor graft, as well as deposition at the same time of bone from the host into the donor graft. So there is creeping substitution of the graft material. So are there biologic mechanisms that provide a rationale for bone grafting? Yes. According to the Newman's and Carranza's 13th edition in chapter 79, Cloakworld has stated that bone grafting is definitely possible because bone tissue has the ability to regenerate completely if bone is provided the space into which to grow. So we have basically two heroes out here. We have the host bone, we have the donor bone. The host bone is nothing but the native bone, the original bone of the individual, and this is the bone replacement material, that is the donor bone or the bone substitute material or the bone graft. What are the biologic mechanisms? We know about osteogenic graft, we know about osteoconductive graft, we know about osteoinductive graft. There is something else called an osteopromotive graft. There is osteoneutral graft. And is there something called osteostimulatory graft? Let's look into that. So what's osteogenic? It contains viable living bone forming cells which form new bone at the host site. Why? They have osteoblastic cells present within themselves. And these osteoblastic cells which are present within themselves, they will form the bone from within the graft itself. There will be new centers of ossification within the graft, like an autograft case. So they will have new centers within, they will form bone from within the graft itself. The donor graft itself is starting to form the new bone. While in an osteoconductive graft, it is basically having a scaffold or a trellis effect. There will be creeping substitution wherein this graft will slowly resorb. And then the host bone, which is outside, the host bone will start invading the cells through the capillaries, and the new connective tissue will come into the donor graft and the osteogenic cells which are in the host bone out here will enter into the graft, and they are the ones which are going to form the new bone. So the graft itself is not going to form new bone on its own. It does not have any osteogenic cells. It's basically the osteogenic cells which is from the host bone, from the bone around, which will come into and start forming the new bone. What about the osteoinductive graft? This donor graft has got certain chemoattractants or osteoactive agents like bone morphogenetic proteins. They will trigger the host bone to for the osteoprogenitor cells in the host bone that is out here. And these will be triggered, these will be induced, these will be stimulated, and they will mature into osteoblasts. These osteoblasts will start entering into the osteoinductive graft through the porous nature of this graft and start forming the bone over here. So does this form bone on its own? No, it does not have osteogenic material of its own. It does not have osteoblasts of its own, but it will induce, it will trigger, it will stimulate the host bone to mature into the osteoprogenitor cells in the host bone to mature, and these osteoblasts will enter here and form new bone formation. What is osteopromotive then? Osteopromotive, the graft on its own cannot do any triggering or promotion or stimulation of the host bone, but it can trigger another one graft which is placed along with it, okay, which has got osteoinductive potential. So this will trigger the osteoinductive potential of another graft, and it will multiply the osteoinductive potential of the other graft, and they will therefore become osteoinductive. So this concept is called osteopromotive, like the animal matrix derivatives, which on its own may not be so osteoactive, but when they are placed along with the demineralized freeze-dried bone allograft, the osteoinductive effect of the DEM bone is multiplied. But then Zynos and others have given a theory wherein they call the osteopromotive as osteostimulative, and they have classified osteopromotive as a physical means of sealing the defect site. So you don't place any material here as such. The material is placed on the top wherein the defect site is sealed. The space is given for the host bone to occupy this area and therefore form a new bone. So they call this osteopromotive, and the earlier osteopromotive was called as osteostimulatory graft. And then we have this gentleman called Ugunsalo in Jamaica. In his PhD thesis, he proposed a theory of osteoobstruction, wherein what he did was that in a single photon emission computerized tomography, in a histological and histomorphometric analysis, wherein he made a pouch of the barrier membrane and he placed porcine graft material in that in a Ugunsalo sandwich bone regeneration technique. And when he placed it into the femur of the porcine animal, he noticed a symptom called a negative mechanism called osteoobstruction. However, and I'm stuck again. This concept needs further validation, and we cannot talk about it anymore. There are other concepts called osteodensification. That's a concept not of using grafts per se in implants. And similarly, we can take that on another day when we are doing more details in grafts. So basically, let's talk about the relationship between the graft material per se, the graft material per se, and the periodontal defect per se. What is the relationship between them? So when we place the graft material into the defect site, as we said initially, after the hemostasis, we had a situation wherein there is capillary ingrowth and the release of the growth factors like platelet-derived growth factor and transforming growth factor beta. And these would therefore stimulate the other osteoprogenitor cells to form osteoblast and therefore produce osteoid. So the immediate reaction is after the hemostasis is revascularization of the graft that we are placing. To achieve revascularization, remember, we would like a pore size of 100 to 200 microns, 250 microns, because this is very conducive to vascular invasion. In case we do not have this porous nature which allows the vascular revascularization of the graft, our graft will ultimately become just a bone filler. Soon after, remember, there is a preponderance of the growth factors. Of course, we talked about PGDF and TGF. Do not forget the factors released by the macrophages, that is a macrophage-derived angiogenic factor, the fibroblast growth factor. Also, remember, the osteoclast activating factor is also being released. Within 14 days, remember the theory of creeping substitution given by Misch in 2012. That is, as the graft is being incorporated, it is gradually resorbed and replaced by new host bone. Okay, so the graft is now generally getting to be mineralized. The revascularization is more established, and you start getting islands of new bone formation. Not yet mature, but yet there are a lot of islands of new bone formation. And by 4 months, we see that the bone integration is complete and remodeling of the bone graft along with the host bone is taking place. And at this stage, the grafted side will be ready to receive either the occlusal loading or the implant per se. How will I know which materials are having which properties and what are the ideal properties? We will have to go into history for this. And if you see the late 1600s and the early up to the early 1900s, basically the studies were on autogenous grafts, which were on cortical cancellous or the periosteum and other bone grafts. And then the early 1900s, it was basically on cancellous graft, wherein they talked about the diffusion of the oxygen and nutrients from the recipient bed. The survival of cells was better with cancellous bone, and that cancellous bone was superior. And then slowly in the late 1900s, they went to allografts, and most of the research done by Urist, and he said that allogenic bone can be replaced by new bone. And around that period, the rules of bone graft procedures were started to be laid down by various studies done by Scalom and Revolt. And of course, Neighbors continued his good work in periodontal surgery by saying that bone shavings are possible need to resolve before new bone formation will be there. Defect fill with the use of bone graft was studied by Melonig, Maffert, Yukna, Seppe, Richardson, and others in the late 1900s, and all of them found that at least more than 50% bone fill was available after re-entry. So what are the requirements in an ideal bone graft? They should be biologically acceptable, non-toxic, non-antigenic. Yes, I would like them to be predictable in bone formation. They should be easy to handle and clinically feasible with minimum operative hazards, minimum post-operative complications like infection, resorption, or ankylosis should be acceptable for the surgical procedure and sufficiently available. And one of the biggest advantages of bone grafts is that they are predictable to reconstruct lost periodontium, as well as we see that they increase tooth support, enhance aesthetics, and improve the function. But the limitation we see is that it requires an additional treatment time, and the treatment is quite technical. You may have post-operative problems, and greater amount of post-operative care is necessary. So we did a lot of basic study out there. Let's now go into the classification of our bone replacement materials. And the first thing that you will talk about is autografts, allografts, xenografts, alloplasts. But actually we should be talking based upon the site of placement as orthotopic and heterotopic. Orthotopic are those places where normally occupied by bone. So periodontal defects are basically, we'll be talking only about orthotopic type of bone grafts. As per the biologic mechanism, we already saw it can be osteogenic, it can be osteoinductive, conductive, or promotive. Based upon the source of the graft, they can be autogenous, allogenous, xenogenous, or alloplastic. And autogenous is when it is transferred from one position to the another in the same individual, while allografts is homografts obtained from genetically dissimilar individual but same species. What if it is genetically similar? So genetically identical recipient but not the same person, like an identical twin, becomes an isograft. Xenograft, of course, tissue transferred from another species. And alloplast, synthetic graft, an inert foreign body implanted into the tissue. We can also classify as osseous and non-osseous. Osseous will be autografts, xenografts, allografts. Autografts could be pedicle graft like bone swedging, free grafts from intraoral source or extraoral source, while non-osseous could be organic or inorganic, organic like collagen, cementum, coral, sclera, and dentine, inorganic like calcium sulfate, calcium carbonate, calcium phosphates, which may be resorbable or non-resorbable. The forms of the grafts can be blocks, chips, particulates, morsels, pellet, strip, paste, injectable gel or putty, while autografts can be the cortical, cancellous, or cortico-cancellous. So we come first to the gold standard, and that is autogenous bone graft. Autogenous bone graft are osteogenic because they contain live osteoblasts. They contain the osteoprogenitor cells. Therefore, they are osteoinductive. Okay, they will contain the bone morphogenetic proteins, which will induce the bone from the host site. So they become osteoinductive, as well as they will resorb in time, and by creeping substitution, they will become osteoconductive. Their success rates are high, they show no immune reaction, and they have a microscopic architecture which is perfectly matched to that of the host bone. And of course, they have minimal post-operative resorption. They can be taken from the ramus, from the symphysis, or extraoral sources like the iliac crest. They can be a cortical, cancellous, or combined source. They can be particulates or block. When you compare the cortical and the cancellous bone, the cancellous one is quite more porous, as we saw in the bone basics. They're easy to manipulate because of its medullary spaces. They revascularize quite easily as compared to the cortical. They contain only viable bone. They have a lot amount of cells, while the cortical will also have non-viable bone. However, the cancellous has got no mechanical strength, hence will be a problem in weight-bearing areas, and extraoral donor site is the iliac crest. Of course, the cortico-cancellous bone will produce the best results. And when we look at the donor site, the extraoral, as I said, the most common one is the iliac crest, can be also from the ribs and cranium. However, the argument that you will create such a big surgery in the iliac crest area just to replenish bone in a periodontal defect does not make the extraoral site too amenable for a periodontist. However, the intraoral sites like the healing extraction site, maxillary tuberosity using bone trevines, the edentulous area of the jaw, mandibular retromolar area, symphysis, exostosis are all sites for an intraoral autogenous bone. As we can see here, we can take it from the external body in the retromolar area, the anterior body of the ramus, the tuberosity, the symphysis area, any torus which is present. Now I would like to show you all a few instruments which are specific for bone grafting. Those who are especially using the mobile phone, I would suggest that you can pin my video screen, or if you all want and the moderator madam allows, we can redo this at the end of the session. So we have something called a bone trap in a suction tip. And the bone trap is you're using it for suction, you're doing an osteoplasty, and you can actually open this, and you got a small sieve out here. There's a sieve, and the bone particles will collect, the bone dust, the bone chips will collect in this. You can place this into your bone well, and therefore you have collected the bone graft material. We shall be seeing one video later on wherein you can collect the bone even from the drills that you're using. The next is the bone scraper. And the bone scraper is an instrument like this for removing the scrapings of the cortical bone on the outer border of the mandible. And it's got a sharp edge over here, and it's got a small vestibule out here, wherein the bone material can collect, as can be seen in the picture here. And there's a sharp edge, remember, out here. So this is a cortical bone scraper. You get something called a microsaw kit. So you will use an external irrigation step down handpiece, and you get a small saw like this. If I can show it to you closer. And the saw is put on this external irrigation handpiece, and you can use a microsaw kit. We shall see examples of this as well. You get bone trephines of different sizes. So I'm sure many of y'all must have gone to these events like your fairs in the small villages, and you'll have eaten this ice creams on the stall. They are called golas, I think so, and they are with crushed ice. So just like that, you get, when you use a trephine, it will be hollow inside. As you can see, it comes in different sizes, and you can put it into, especially in the symphysis area, and all the bone will be there in the trephine area. You will slowly, you get a small, just it looks peculiarly like that gola, okay? And probably it will get you a lot of success with your bone grafts. And then you have a bone mill. This may come as a handheld or a tabletop, wherein you'll put your cortical bone chips inside like that, and then you will take it, and just like how you'll turn it like this, so you can crush your bone chips. My PGs tend to call this as the Limbo Maker. So they'll say, where's the Limbo Maker, sir? And you have bone well. The reason I'm showing this, it's not a simple katuri. It's actually quite heavy, and so that it does not get displaced. This will help you to take your bone graft, be it autograft pieces, be it what you have harvested during your osteoplasty, be it your allograft, and you can take it close to the surgical site and dispense it. You will get a bone carrier, so it will have a scoop at one end, and there will be a condenser in another end, so that you can condense this into your bone graft. And this is very, very interesting. Comes in three sizes. This is a bone graft carrier. It comes like this, okay? And what is done is you'll keep your finger at the bottom like that. And I don't like to use the, many people say you can use an amalgam carrier, because an amalgam carrier, you'll have to tap your bone graft material like that and fill up this. So it will be quite small increments. In this, if you can keep your finger like that, remove the plunger from the top, and if you notice there is a small funnel here, and you ask your assistant to drop the particulate matter into the funnel. Do not overfill it inside, because anyway you have to put it in small increments. Just fill the bottom part. Remember, the internal part should not be wet, others the particulates will clog and jam your bone carrier. And then you put your plunger inside, and once you put your plunger inside, you tilt it up like that, and then you can take it to your bone grafting site with enough of ease. And also important at this stage, we shall be talking later on about the pins, the bone pins for stabilization of our onlay graft. So you get small bone pins like this, okay? It's I hope you all can see it. And these pins will be, you'll get special instruments to hold the pins, and you will put it into this instrument to hold the pins, and then stabilize your bone graft. And prior to that, of course, into the host bone, you'll get special drills like that. And with these drills, you will be able to first make that initial hole, and then you will put the pins, as well as you get small tacks. These are small tacks. I call them tacks. You can call them pins. And these are used for stabilizing your membrane. They're very, very tiny. I do not know whether you can appreciate it on the screen. So how do we harvest our autogenous bone graft? Here we are using a physio dispenser wherein we'll give a cut and we will remove the cortico-cancellous ramus bone graft. Remember, when you're using it for implant site development, you will have to stabilize your onlay graft by using your bone pins. Okay, and you can also use a burr with a slow speed handpiece using copious irrigation. When you're using the burr, you can collect the bone chunks and pieces also, and you can place your onlays, and the in-between area will be filled up with this small material here. You can use that micro saw, so you'll give a distal cut for the required thickness. You'll give an anterior cut in the posterior buccal border of the mandible. You'll give the anterior cut. You'll give an inferior cut like this. And then afterwards, the superior cut will be with a long burr such that you connect with the cut down here. And then with a chisel, you will displace it. Corey Enhancer has given a modification wherein he slices this cortical part of the body of the mandible or the ramus. He slices it into two. And so he gets the cancellous, the inner portion, and he gets the cortical outer portion. The cortical outer portion is placed back at the donor site. It's stabilized with one pin back at the donor site, while the cancellous portion is stabilized at the host site for your implant site development. So the outer portion is stabilized here, and the inner portion is stabilized over here, the cancellous, the one with the internal cancellous part. But you must be careful when you're trying this. See that you take your CBCT, because sometimes the inferior alveolar canal may be very close to the buccal border of the ramus. And if you were giving the inferior cut or removing this cortical bone, you may damage that nerve. So you can see after 6 months, the donor site has healed quite nicely, and the implant site development has been good. And we were able to place 3 implants by the technique Microsoft protocol of Corey and Henser. This was a technique in the symphysis area, which Dr. Bhagwandas Rai from Udaipur and I had developed at Bagalkot in our days at Bagalkot way back in 1995, wherein we would take a cortical bone window in an area quite inferior to the apical ends of the lower anteriors after taking the proper radiographic evaluation. And then after we remove the cortical bone window, we would harvest the cancellous bone underneath. So we could get a pure cancellous bone graft, place the cortical bone window back, and you would put a pressure bandage on the top. Or you can even use this cancellous cortical bone for onlay grafting. If you're doing that, this site would have to be replenished with maybe a xenograft or an allograft or some other material. The trephines, as I told you, are the best for taking the symphysis area chin bone graft. You will get a cortico-cancellous bone graft for this. You can also take a cortico-cancellous bone graft from the zygoma area, but be careful when you're doing it. Preferably use a piezo-surgical unit, because remember, the membrane of the sinus, maxillary sinus, is very close and you do not want to puncture that. You can take by intraoral cortical bone shavings along with that bone scraper, but there is potential for sequestration if you have not seen that it is properly vascular. And trephines, again, you can make a nice blend out of it, and as per the size of your trephine, you can collect a lot amount of bone by this technique. There is another technique which is talked about as osseous cogulum. The same bone that which you found in your bone trap or otherwise collected during your osteoplasty procedure, you can use that after it has mixed with blood and use it with quite appreciable results, as mentioned by Robinson in 1969. Then there is a technique called bone blend, wherein you take the bone particles that you have got during a surgical procedure like osteoplasty or osteectomy, and then you put it in an autoclavable plastic capsule, just like how you would have put your amalgam powder and mercury. And then you triturate it, and therefore you get a nice blend of the tissues, which is very easy to dispense and pack into the defect. Just for academic sake, you get something called a pedicle graft. Others usually grafts are all free, but there is a situation of a bone pedicle graft wherein you use it in the situation of a one wall defect adjacent to an edentulous area. You give with a burr a fine cut about 3 mm at an angle anterior to the defect, and then with a chisel you displace this graft. Remember, it is still connected at the base, and then you swatch it onto the tooth surface such that the defect is covered. This area, void over here, may be covered with particulate material. This technique is called bone swedging. So remember, the healing of bone grafts is by the viable cells, therefore it's osteogenic. It is because of the inductive potential of the bone morphogenetic proteins to transform the osteoblast in the host to form new bone, so it is osteoinductive. It does have a porous nature, and it will get resolved over time by creeping substitution, therefore it is a scaffold. Therefore, bone graft is incorporated into the recipient side through remodeling and gradual replacement with new bone over time. This was stated by Misch in 2012. The moment I say Misch, I think so all of you all will be thinking about the late Carl E. Misch. Okay, I'm not talking of Carl E. Misch, I'm talking of Craig M. Misch. Who is Craig M. Misch? Craig M. Misch is a periodontist in the USA with a lot of work in implant site development. In fact, he's written a beautiful chapter on bone grafts in the textbook Implant Site Development. And he actually happens to be much more handsome than Carl E. Misch. I do not know whether he's available, but all you young girls out there and who are interested can think about finding out. Okay, so we're talking about Craig M. Misch, the younger brother of late Carl E. Misch. Okay, so the most important thing, coming back to the topic in autogenous bone healing, is the revascularization of the graft. And they say that the cancellous portion of the graft revascularizes faster, as we discussed earlier, while the denser cortical bone will revascularize to the existing Hevesian system and the Walkman canals if there. Remember, Misch has given us the theory of creeping substitution. That is, the osteoclast will slowly resorb the graft. These osteoblasts, remember, are coming from the host bone, while the osteoblasts coming either from the donor donor graft or the host bone actively slowly forms the new bone. So within approximately 7 months, the cortical bone grafts are remodeled with vital bone. The cancellous will take much lesser than that. So Craig Misch has given us this nice diagram to show the nice histo slide to show the graft resorption is an inherent consequence of graft healing and the creeping substitution and incorporation into the osseous recipient site. So the questions were asked regarding, does the microarchitecture play a role, or is just the embryologic origin of the graft which is the influencing factor? Because they found that membranous origin grafts perform better than endochondral grafts. But then later on, it was understood that it was a microarchitecture, that the denser cortical grafts, they resorb less than the porous cancellous graft, and therefore they take more time to get integrated with the host bone. But they, remember, are more weight bearing and can be used in the areas of more load much more easily. So now we are talking about Carl E. Misch, and he said that cortical bone grafts from the mandible exhibit minimal resorption and maintain their dense quality upon healing, making them ideal for only augmentation prior to implant placement. So coming back to Craig Misch, when using iliac bone block bone grafts with a thicker cancellous component, it is prudent to overbuild the grafted site in anticipation of some volume loss over time. These et al. In a study with 46 successful implants have found that the donor site is also important for a success of our autografts. He said that grafts taken from the mandibular symphysis are better than the ramus, which are better than the maxillary tuberosity. But Clevero and Lundgren preferred the ramus because they said the ramus grafts encounter fewer complications and morbidity. We will look at the morbidity, these disadvantages later. What about the maxillary tuberosity? It has a softer consistency, more trabecular pattern, the porous and thin outer cortical layer. But the problem is that it is deceiving as to how much of amount of bone it can give. So when you look at the tuberosity with the soft tissue covering, you think that you're going to get a lot of bone. But the moment you open it up, you see that the soft tissue was very thick outside and the actual bone underneath is quite less. Also, the problem of the anatomical limitation. There is a sinus present anteriorly. There are pterygoid plates present posteriorly. There's a greater palatine canal present palatally, and of course, the second molar or the third molar tooth. How do we do the maxillary tuberosity graft harvesting? Because that's one of the favorite for getting the autografts in periodontal therapy. And that will be harvested with a chisel or a ronger after you raise a full thickness mucoperiosteal flap, sufficiently buccally, sufficiently palatally. But remember, shave off your pieces, preferably with a chisel, using very, very slight force, be very, very superficial so that you do not create a sinus communication. Mish has also suggested you may even take carefully a thin piece of cortical bone in case you require an onlay for your site development. What about use of membrane? Busser and all have talked about using a barrier membrane. Then he talked about a non-resorbable membrane. Nowadays, he suggests use a resorbable membrane. This will give you better clinical success. But Gilkins and others have said that there is insufficient evidence to conclude that the use of a barrier membrane is effective in diminishing the resorption and improving the incorporation of your onlay bone graft. But Herman has talked about that if you are using particulate graft matter in between the blocks, the membrane is better, and the membrane which is preferred is the collagen membrane. So now there's an onlay graft over here. There is particulate material used here. A membrane has been used, and after 4 to 6 months, you have noticed that there is a very good implant site development and the incorporation of the bone grafts. What is the predictability? The autogenous bone grafts, block grafts, remember, are the gold standard and can be used to restore both function and aesthetics predictably. Disadvantages: limited availability. You need to do another surgical site. You can have a risk of nerve injury, quite a lot of swelling at 2 places, compromised mouth opening, sensory disturbances of the lower lip, nil sensation, and of course, with the iliac crest, you have the obvious problems extraorally. So how do we do the procedure of the autografts? First of all, the preparation of the recipient bed. It should be prepared before the graft harvest. And the typical incisions are the papilla preservation incision, clavicular incision, or a crestal incision. But more importantly, give good releasing incision such that you can see the defect very well. In case you want to place a membrane, you'll have to go at least 3 to 4 mm apical to the apical border of the defect. A broad mucoperiosteal reflection well beyond the defect, therefore, is essential. Remove any soft tissue remnants from the defect site. Also important is to prepare the recipient bed and understand what would be the size of the bone block that you will be using, such that the fit and the contact of the bone block to that defect site is the best. Also important is to decorticate. How do you decorticate? You can take a small round burr and just make holes such that you do not damage any vital structures inside, like the apex of the adjacent tooth, etc., but such that you will get good bleeding spots, which will therefore release growth factors. It will expedite, it will improve, hasten the revascularization of your donor graft, and therefore improve the graft to the host union. So how do we harvest the block graft? In the textbook by Kalsi, published in 2019, he talked about that the temperature at the site during harvesting must be between 37 degrees centigrade and 42 degrees centigrade. 37, of course, being the body temperature. If you want it in Fahrenheit, it's 98.6. And actually, that's the radio channel you're on. It's called Bone Graft 98.6 FM. And he said that rotary instruments can cause frictional heat, and this frictional heat can lead to the death of your bone cells. And bone cells is required for my osteogenic potential of my autograft. So therefore, use a slow high-speed handpiece with copious saline irrigation. After harvest, wrap the bone graft in sterile, saline, soaked cotton gauze and not keep it immersed and dipped in saline solution. Do not place it in antibiotics. Do not chemically treat it. Do not expose it to high intensity. So all in all, you are harvesting your block bone graft carefully with copious saline irrigation, and you have done this only after you have prepared your recipient bed. So the amount of time that the bone graft is outside the body is reduced. Take the bone block graft to the site in care. Otherwise, you can use this special instruments for holding your bone block. You can hold the bone block here and then tighten it, or you can use your Ellis forceps. Orient the block such that the cancellous side of the block is towards the host bone. Fixate it with those titanium alloy screws, 1 or 2 mm. When you're fixating it through the host bone, it will be a tight fixation. So you'll make an initial small hole, and then afterwards you'll fixate it. But it will be passively fixated. The hole in the cortical bone graft will be made prior, and it will be slightly bigger than the screw itself. You will not make this hole tight, remember, otherwise you may cause microfractures in your onlay graft. Use 1 screw for small block grafts. Use 2 or more. So if you're using just a small graft like this, use 1 screw only so that you don't make too many holes. If you're using a bigger piece, 2 or more screws are used to fixate it. Those screws can also be used for tenting of the periosteum for the remainder. In between the onlays, you can put your articulate material, which could be your particulate part of your ground part of your autograft. It could be your allograft, or it could even be xenografts. Need for barrier membrane, as you said, is debatable. If you're using particulate graft, then definitely use a barrier membrane. Use a tension-free closure is necessary, so give a periosteal releasing incision. If you require further flap release, you can use blunt scissor or a hemostat into the vestibular depth. Splinting of the adjacent tooth may be necessary, or of the tooth itself may be necessary in case there is increased mobility. So we now progress to allografts. As you know, they are from human cadavers or even human living donors. Unlimited availability, avoids the morbidity of the second surgical site, but they are only osteoconductive. Demineralized freeze-dried bone allograft is said to be having bone morphogenetic proteins which have not been sequestered because of the demineralization process, and therefore they may be osteoinductive. However, they have a risk of infection transmission and host rejection. The fresh frozen bone is the first type, but they have a high amount of disease transmission and therefore rarely used nowadays. The freeze-dried bone allograft is processed to remove the moisture. They have a high amount of mechanical strength as compared to the demineralized freeze-dried bone allograft, but they have only osteoconductive potential. And they have been tried in various studies, and they have been shown to be good in restoring periodontal defects. Up to 50% of defect fill. They are resorbed very slowly, and they are usually mixed with autogenous bone to make it osteoinductive. So as I said, Melonic, Sepe, and have done a lot of studies, and and have shown more than 50% bone fill in the defects and comparable, slightly not as good as autogenous bone grafts, but nearly up to there. The Yukna and Sepe have tried freeze-dried bone allografts with tetracycline antibiotic, and he has talked about 50 to 100% bone fill in his various sites that he has placed it. The demineralized freeze-dried bone allograft is also called allogenic autolyzed antigen extracted bone or demineralized bone matrix, or during RPG days we used to call it DEM bone, and we liked it because of its easy maneuverability into the defect site whenever you mixed it with little bit amount of blood. However, it has lesser mechanical strength as compared to the freeze-dried bone allograft, but it has osteoinductive potential simply because the demineralization process exposes the bone morphogenetic proteins, while in the case of the freeze-dried bone allograft, these proteins got sequestered by the calcium which was not demineralized. They are indicated for osseous defects, implant sites, and socket preservation procedures, and they stimulate the bone formation due to an osteoinduction. However, you must note that younger person donors will have the greater amount of bone morphogenetic protein as the older donors. So the ideal particle size is around 250 to 500 microns. This size permits a high inductive potential because if you had a smaller size, they would have got resolved much faster, and a bigger size, they would have got a problem during the integration. So the larger ones will not be well integrated, and a smaller size will elicit a macrophage response and faster resorption. So this size becomes ideal for expressing the bone morphogenetic proteins and the osteoinductive potential of the DFDBA. Again, a lot of studies has been done by Bowers, Melanig, and Laurel, both in comparison with the autografts as well as with just open flap debridement. They found a similar osteoinductive potential as compared to the autografts, while a similar, much better effect as compared to open flap debridement. So therefore, the demineralized freeze-dried bone allograft is useful in probing depth reduction, attachment level gains, and in osseous regeneration. And they produced more bone fill than freeze-dried bone allograft and results in 2.5 to 3 mm lesser than autogenous, but along with guided tissue regeneration, probably it would be much more successful. So after the autogenous bone graft, the demineralized freeze-dried bone allograft is the one which is most preferred because of its availability, predictability, biocompatibility, osteoinductivity, osteoconductivity, cost effectiveness, and safety. However, there is disease transfer. Did you know about the processing of demineralized freeze-dried bone allograft? You take the harvesting either of cortical or cancellous bone from the cadaver, then it's roughly cut to a particle size of 500 microns to 5 mm. Then it is immersed for lyophilization in 100% ethyl alcohol. It is further ground to 250 to 750 microns and then decalcified in 0.6 neutral hydrochloric acid. The excess residual acid is removed with a sodium phosphate buffer. Then it is frozen at minus 80 degrees centigrade for 1 to 2 weeks to interrupt the degradation process. And after this is complete, it is subjected to bacterial culture, serological test, antigen antibody analysis to see that it is viable. The concern, however, is the transfer of infection by using allografts. Mere freezing of the allografts decreases the risk of transfer of disease, viral transmission, particularly HIV, to 1 in 8 million, while demineralization process will make this chances of 1 in 2.8 billion, according to Russo et al. In 1995. So when we compare demineralized with the freeze-dried bone allograft, you know the demineralized freeze-dried graft or the DEM bone is demineralized, has got the expression of bone morphogenetic protein, therefore is osteoinductive in addition to osteoconductive, However, because of the demineralization, it will be more radiolucent, so maybe you won't be able to appreciate it properly on the radiographs. It has got a faster resorption as compared to freeze-dried, and the primary indication is very good results in periodontal defects. Now coming to xenogenic, they are from the bovine, porcine, or equine sources, and out here comes an controversy. So in case you are using it in your client, and we know that India is a multipolar society, so in case you are using it in your client, I think so, in my opinion, it is imperative and necessary at the informed consent stage to explain to your client that this particular graft is a bovine origin, or this particular graft is a porcine origin. Because if the client has got some religious convictions and in the matter of his faith, which does not allow him to use material for medical purposes from bovine origin or from porcine origin, depending upon his faith, then you can think about using a substitute, because once you use it, there won't be a rewind button for you. So it's better, in my opinion, to explain to the patient what you're using, and he says you can go ahead, then on your informed consent, you can write it and take his signature. The other problems is the immune reactions, but then of course during the deproteination processing, you can reduce this antigenicity, and we know that xenografts are mainly osteoconductive. If you look at how the inorganic bone or the deproteinized bovine bone is prepared, it's first ground to particulate, and then the lipids and the proteins are removed through rigorous washing and high temperature sintering. And then you get this low crystallinity achieved at 600 degrees. And after that, you do a terminal sterilization via gamma irradiation. When I say you do, I mean it's already previously done. You get it totally packaged. Okay. So you can have cancellous or cortical. Remember, it's quite porous and therefore it's osteoconductive. It is biocompatible with most tissues, and it's available in various sizes and has been successfully used both for periodontal defects and implant site development. Its advantages obviously are the unlimited supply, it being safe, biocompatible, possesses the same structure as the bone, and the porosity allows its good osteoconductive nature. However, the disadvantage becomes the case of disease transmission like bovine spongiform. You have different, this being trivia, I'll go fast through that, like keel bone, ospurane, boiled bone, anorganic bovine bone, bow plant, and bovine anorganic cancellous bone, porcine non-antigenic collagen. And nowadays, very much in use is the BioOs, which are cancellous and cortical granules. And you get BioOs collagen also, which comes more like a sponge-like material with a large internal surface which functions as a scaffold. Very common in India, a made in India product is Osteograft, again of bovine origin, and Osteobiol is of porcine origin, and the PepGen P15 is a porcine inorganic graft containing synthetic 15 amino acid sequence with steric similarities to collagen. You have also a xenograft. Many textbooks call this as a xenograft, which is nothing but made from coral skeleton. The trade name is Interpo, which can be non-resorbable or resorbable. However, I've included this as alloplast because though it is from a xenogenous source, it is not having an exact structure as bone material per se. So therefore, I've included as alloplast. Coming to alloplast, referring to the review article I published in 1995 along with my guide, it's a synthetic biocompatible, inorganic, chemically diversive, bioactive, osteoconductive material, which can be resorbable or non-resorbable. And when we talk of the various types, they can be biomaterials like sclera, collagen, coral, or dentin. Could be ceramic like calcium phosphate, hydroxyapatite, plaster of Paris bioactive glass, or tricalcium phosphate, or polymers like HDR polymer, or even could be the fillers like used for metal in guided tissue regeneration. The alloplast mainly we talk about is hydroxyapatite, tricalcium phosphate, HTR polymer, and the bioactive glass. The basic advantage is the absence of antigenicity, no potential for disease transmission. However, the 1996 World Workshop in Periodontics concluded that along with the American Academy of Periodontology's position paper, that these materials function predominantly as osteoneutral biological space fillers. So you have ceramic-based bone grafts, which can be the calcium sulfate, phosphates, and the calcium sulfate is basically a plaster of Paris, which has got high amount of stress, medically grade plaster of Paris. But remember, they require a dry environment to set, and mainly they are biofillers, and they may not resorb over time. So they integrate by a bio, if you can call it integrate, by a bio-exclusion principle. The tricalcium phosphate are basically of the Wittlockite series, which can be alpha tricalcium phosphate, which is monoclinic, or the beta tricalcium phosphate, which is partially resorbable, they say, but mostly they are biological fillers. So you get the beta tricalcium phosphate is usually encapsulated by fibrous connective tissue. You get biphasic of combination of the alpha and the beta. Further studies, however, are needed before clinical acceptance of these materials. There is an injectable calcium phosphate cement, which they say is gradually replaced by natural bone, but no superior clinical outcomes are seen vis-a-vis open flap debridement. You get hydroxyapatite, which has got a calcium to phosphate ratio similar to that of bone, being 1.67. Depending upon the sintering, you can get non-resorbable dense material or porous resorbable material. So the dense one being non-resorbable will be inert biocompatible fillers, while the porous ones are absorbable, and they'll have usually a pore size of 190 to 250 microns. They come in different granulations and are quite cheap, readily available, come as paste particles or blocks. The porous hydroxyapatite, this is what I love about them, is a very hydrophilic. So you add a couple of drops of the patient's blood and you get a nice gel-like material which you can place into your defect very easily. But you should be careful in not putting too much of blood, otherwise it will all wash away. Okay, so you get good clinical defect fill, good probing depth reduction, and good attachment gain has been reported. Kenny has talked of also supporting bone formation. But whether we get actual new cementum, new attachment, and histologic evidence of new attachment, we do not know. So bioactive glasses are also present, and these they form a calcium phosphorus rich apatite layer on the surface. And one of the examples is Perioglass. Another example is the Biogran. In Biogran, they say that the small cracks are formed in the calcium phosphorus layer, and this formation of protective pouches is where the osteoprogenitor cells will adhere, differentiate, and proliferate, and therefore you will get new bone formation. You get HTR polymers, which can be natural, synthetic, or copolymers. They're basically used as barrier materials in guided tissue regeneration procedures. An example is bioplant, and most reports have supported the use as a bone substitute. You get biomaterials only for trivia purposes. Once upon a time, use sclera with good results, cartilage, and we talked about the xenograft from coral called Interpore. And this is a recent development, and that is demineralized dentin matrix by Kim, wherein he said that the tooth is composed also of inorganic components and organic components. Inorganic like hydroxyapatite, tricalcium phosphate, octocalcium phosphate, amorphous calcium phosphate, etc. And organic like collagen. And so if you take the non-restorable tooth or a third molar, you extract it previously, and then if you treat this tooth and make it either into a block or make it into a paste, you can use it in periodontal defects. So the extracted tooth is stored in 75% ethyl alcohol. The periodontal ligament area is cleaned up of all the soft tissue remnants. The dissection of the anatomical crown is done. It is ground into a powder form of 400 to 800 microns. Contaminants are cleaned with distilled water, subjected to dehydration, defatting, and lyophilization, as well as demineralization in 0.6 neutral hydrochloric acid. This is how it is made. And in South Korea, team has developed a sort of a lab wherein they can you can extract the tooth and send it to the lab, and the lab prepares it and sends your bone replacement material to you. So after a week or two, you can use that bone replacement material in the same patient. So it is autogenous demineralized dentin matrix, and use it in the same patient with good results for periodontal defect regeneration and implant site stability. Also, one has to remember that the bone has got osteoactive agents. We can use osteoactive agents for osteoinduction or osteopromotion of the bone defect, and therefore get bone replacement. They are like bone morphogenetic proteins. The trade names are Novosis and Inductos, Osteolateral, etc. So when you compare the autografts with the allografts, xenografts, and alloplast, you see that the autograft ticks all boxes except the problem of the second surgical site. So it is, yes, the gold standard. And the next best comes the demineralized bone matrix, which, except for being osteogenic, ticks virtually all the boxes. So if you're awake, we can go for a small water filter break. And let's look at the procedure, steps, and tips. And here comes Carl Misch's 11 keys to bone grafting. It depends upon your defect size, depends upon your topography, depends upon your asepsis, soft tissue coverage, space maintenance, your graft immobilization, stability or fixation, the regional acceleration phenomenon, the host bone blood cells, growth factors, and healing of the regeneration time, the graft material that you're using, and the transitional processes. And then when you look at the steps, you have a lot number of steps. Out here, I would like to come back to that photograph which I showed you with respect to me sitting with my guide. Rather awkwardly, I was trying to be comfortable sitting next to him. I can't imagine actually sitting along with him. And around that time, he asked me a question and he said, Aaron, what is your experiences with bone grafts after all these years? And then I said, you may use this graft, you may use that graft, you may use this graft or that graft, whatever the name is. Ultimately, what is important is your phase 1 therapy. You should get that site non-diseased. There should be no bacterial contamination over there, such that your tissues are amenable for surgery. A large number of us in an inflamed condition will be doing the bone graft. The bone graft will be placed at the site and it will wash away with all the bleeding, and we are not able to manage the soft tissue because it's not firm and fibrous, because we have not given sufficient time for re-evaluation. Then I said most important is the root preparation. Just because we're using a bone graft which is more expensive, we are tending to do a much better root debridement. But when we do open flap debridement, we are not debriding that area too well because we are not using an expensive material. So I said, in my opinion, your basic steps of your open flap debridement, be it your phase 1 therapy and your re-evaluation, debridement of the defect, root preparation are as important as the graft material that you are using. So your patient selection should be in good physical health, good oral hygiene, long-term ready to maintain his oral hygiene, non-smoker. Your defect, usually the 3-wall, 2-wall defects will be much better than the 1-wall defect. Craters will be much better. Enforce your plaque control preoperatively, complete your phase 1 therapy, do your occlusal therapy with splinting or coronoplasty. Reevaluate after your phase 1. Use a pre-procedural rinse. I do recommend, I still, even in my old age, try to maintain my case records, maintain my radiographic evaluation of my patient pre and post, and try to do my photography of my cases. Anesthesia, you may go for a nerve block and or local infiltration. Local infiltration will help you to get good bleeding control, especially in the soft tissue side. Your flap design will be a conventional flap. Papilla preservation will help in non-dissolution of the graft if you're using particulate material. See that you do full thickness flap well beyond the defect, if possible beyond the mucogingival junction, if you want to attain good flap closure afterwards. So you can see a circular incision has been given, and you have debrided, you have isolated the defect, you have reflected the mucoperiosteal flap well beyond the defect. You will now get 3 zones: soft tissue zone, the bone surface zone, and the root zone. The bone and the soft tissue, you have to debride it very, very well. Many of us do not do flap thinning. You may have to do flap thinning without tearing the flap, okay? And this is possible if you have gone through a good phase 1 therapy. You see that all granulomatous tissue are removed, all soft tissue remnants are not there. There are no tissue tags on the bone side or the tooth side. You should permit an intimate contact between the graft material and the bone. It is essential to have good root surface debridement, remove all calculus, all remnants of junctional epithelium, all bacterial plaque and calculus has to be removed. The cementum has to be scaled properly. You can use ultrasonic, of course, in this COVID environment, you can't. Hand instruments. You may use even finishing burrs in the proximal areas which are not accessible to your fine curettes. You have to use Quintin furcation curettes in the furcation area for good debridement. So you've seen a fine burr, but do this very, very carefully at slow speed with good irrigation, such that you do not gouge the tooth surface. You will then do root preparation with treatment of one freshly prepared 1 pH citric acid, or you can detoxify also with tetracycline or use fibronectin solution. You must encourage a bleeding bony surface, but not that the bleeding is too much. If the bleeding is too much, you have to control it, otherwise your graft will wash off. Pre-suturing is another important tip, not there in the textbook. You give the sutures like how you would have given at the site, but do not tie the knot, just leave them loose. So now what happens, after you have placed the graft, you can just tighten it at one go. There is no need for you to pierce into the soft tissue, because the moment you pierce into the soft tissue, you will encourage extra bleeding. You may prefer vertical mattress or intrapapillary suturing for using a good closure on the top. But remember, you have not yet tightened your suture. Select your graft based upon what type of defect it is. Demineralized freeze-dried bone allograft is preferred, or you may use a xenograft. Place your graft in small increments. Remove any excessive fluid after you're placing the increments. You can put a squeeze cloth, sterile squeeze cloth on top of the suction tip, and then dry the defect and then place the next increment until the defect is filled. Defect should be filled up to the defect filling point. Do not go for overfilling. If you go for overfilling, it will result in a situation that you will not be able to close your soft tissue flap properly, and definitely not an underfilling. Overfilling becomes preferred to underfilling, but best go for just about filling. So we have placed the graft material in the interdental area and the slight grade 2 furcation which was there. The flaps are then approximated with digital pressure, and the tissue coverage of the material is checked. In case you're not getting tissue coverage, you can give, as I told you, those periosteal releasing incision, or you can do a reflection deep into the vestibule. During the suturing, you should avoid dead space under the flap, avoid excessive clot formation, avoid interposition of the epithelium or necrotic tissue between the flap and the bone grafts. and avoid hematoma formation. These avoids have been stressed in the textbook by Calci in periodontology. And the monofilament suture is used to close the flaps by the primary suture. You will give a periodontal dressing preferably for up to 10 days. Nowadays, it's debatable. Many people do not like giving a periodontal dressing. By not giving a periodontal dressing, there is the possibility of impingement of foreign materials, flap displacement, and loss of bone graft. Tetracycline type drugs are the preferred antibiotic. You may give dexamethasone in case you feel that the surgical procedure was for a long period and the chances of post-operative inflammation are high. Otherwise, preferably not given. And you will give these doses for about 5 to 7 days, and topical antimicrobial rinse may also be given. Dressing is retained for 10 days. After that, you will call the patient for 3 visits every 10 days. That is the first month. And then every month for the next 2 months, and then every 3 months thereafter. Remember, the site should not be probed prior to 6 months, depending upon the type of graft you have used. Most of the xenografts take about 9 months for integration. The cancellous grafts take about 3 to 4 months. The cortical grafts, as you've seen, is taking around 6 months. So radiographs also taken prior to 6 months may not give a good result. Pre-operatively to post-operatively, you see that you get good results, and radiographically also you will assess, and you have seen that you have got good bone fill. But are these the methods to see whether your graft is successful? Clinical methods and radiographic methods? No, actually probably CBCT, surgical re-entry, histologic methods, and animal methods. When you talk about CBCT, if you use the 3D sectioning of the models of your CBCT, your DICOM images of your CBCT, and you use a software like ITK Snap, you can do a 3D reconstruction by using the various segmental sections of that defect. So you can do a 3D reconstruction of the defect prior to using the bone graft, and probably 9 or 12 months after using the bone graft, and you can actually appreciate how much this has helped. Or you can do surgical re-entry, but of course ethically this will be controversial to see how much is your bone fill. But yes, you will not be able to tell where the histologic attachment is. For that, you'll have to do histologic studies. But for this, you have to extract the tooth that you were trying to save in the first place. So is it feasible? No, it's not. You will only get a point of principle with that. Or you can do animal models like how I had done. You had taken a New Zealand white rabbit and did a iatrogenic defect and filled it with the test material and compared it at the sham treated site. And you could even do a histologic study at, say, of the mandible of the animal. And if you use many mandibles, like I used 20 rabbits for this study, and you could do the histologic study at 1 week, 2 weeks, 4 weeks, and 6 weeks. What about bone grafts with GTR? How will I do this procedure? So you have placed your bone graft and you would like to place a membrane on the top. Remember, GTR is based on the Melcher's 1960s hypothesis of cell repopulation, and it avoids the apical migration of the epithelial cells and leads to periodontal regeneration over here, because it has secluded the defect for the regeneration of the cells only from the periodontal defect. And basically, you have got 3 generations of the membranes: the non-resorbable membrane. The resorbable membranes are the second generation, which can be natural or synthetic. And the third generation, according to Gottlow, is the resorbable membranes with the growth factors. Basically, the technique is the same as the technique used for the bone graft, except that you may require a little bit more reflection, up to 3 to 4 millimeters. And just before you cut the membrane, you will first, in a tin foil, make a template of how big the membrane is. I will show you these pictures later on, wherein you can actually get the membrane size. So you've seen grade 2 furcation defect, but quite with a big vertical depth. Bone graft has been placed, the membrane has been adapted, and then the flap has been sutured so as to cover the membrane always. And after 12 to 18 months, a good success rate. Same scenario, defect, interdental, that was a furcation defect. This is an interdental and a buccal defect, palatal defect, sorry. The membrane placed and sutured to cover the membrane. You can do guided bone regeneration for implant site development, placement of the bone graft, placement of the membrane, suture to get primary closure, and then you see when you re-entry for placement of the implant, good development of the implant site. You can think about bone graft plus membrane plus platelet-rich fibrin. I won't go into platelet-rich concentrates because my dear colleague, Professor Deshpande has already covered that up. So we did this study back in our department wherein we used a technique of all three in a sandwich format, and we used it, very successful results. We got up to 90% bone fill even in grade 3 furcation and maxillary furcation defects, wherein after raising of the flap, we placed the bone graft material along with the platelet-rich concentrate. So you got something called sticky bone. A template was made, I said, in tin foil, such that the membrane was cut in the same size so that you can adapt even into the interdental areas. The membrane has been adapted. And after the membrane adapted, the platelet-rich concentrate was previously kept underway and made into a sort of a membrane. And so we had 3 layers and we got quite appreciable result. Can you do guided bone regeneration, that is bone graft with membrane with fixture at the same time? Yes, you can do, provided your primary stability, the ISQ score is anything more than 60. And yes, do not load the implant immediately. So implant placed, augmentation done on the buccal, ISQ score plus 60. Remember, whenever you're using membrane with the fixture, you must think about using the fixation pins or tacks, which I showed you, or suturing the membrane in case it's a non-resorbable membrane. Resorbable membrane become very gelatinous, so you can't suture it, or use a double layers vertical suturing. I'll show you that suturing technique say. Or what I do is I put the healing cap through and through the membrane, so that stabilizes it quite nicely. What are the suture materials and suture needles that we have to use in bone grafting? We will try not to use your silk sutures because they give a plaque wicking effect, and Vicryl and chromic guard are better. A round body needle is preferred over the reverse cutting because it will maintain the soft tissue integrity better. You can give mattress sutures to get a tight closure, or you can give the vertical mattress non-periosteal sutures also in case it's a longer. This is a technique given by Urban et al. In 2015, especially with respect to the implants, wherein the suture is taken through the palatal flap and hooked underneath into the periosteum on the buccal side where the membrane has been placed, and then hooked back to the palatal side. And you see that the membrane has got well stabilized over here by the suture has come this way, gone here, gone into the periosteum underneath, come back up and gone up. We called it the periosteal vertical mattress suture to stabilize the membrane. Or you can use a Des Tavola suspended external suture. So it sort of creates a ponytail out here, which will later on heal properly. And this membrane is stabilized because stabilization and fixation of the membrane come the bone graft is very, very necessary in the initial stages of the healing. You can use the other technique of using bone grafts is a sandwich bone augmentation technique, wherein there is autogenous bone can be applied as a first layer over the defect or the implant site. And so this will provide the properties which are missing in your xenograft and missing in your allografts. And then you apply a layer of particulate bone substitute, which may be xenograft or allograft. They say try to perform an over augmentation, though I feel over augmentation should not be done. and perform this technique with the use of membrane is mandatory. So you had a defect site here, placement of implants, the autograft which has been harvested from the same individual has been placed. How do we get this autograft? So when you're using your primary pilot drills for your implant, if you use at slow speed with very less irrigation, you will see that the cancellous bone sticks onto the pilot drill. I'll show you a video of that, and we can look at the that's amount of autogenous bone. After you place the autogenous, the beta tricalcium phosphate has been placed on the top, and then the membrane has been placed on the top. So you get a sandwich technique, or you can do it with xenograft also, autologous place, xenograft place, membrane placed, and you'll get good results at re-entry. How do we get that autologous graft besides the bone traps and the trephine drills? You can even get it if you do with low speed and very little irrigation. If you're using no irrigation, remember your speed has to be real slow. We're talking about something like 50 to 100 RPM. Okay, so you can also use it for implant site development. I'm showing you the case from Craig Mish's case. The removal of an impacted cuspid left a big defect. Place your cortical bone graft to augment the implant site. A collagen membrane has been adapted, and you have sutured after that. And when you went to remove the pin, you saw that good implant site development, and the implant can be placed in the healed bone graft. And the final implant is in position, and the crown is fabricated following the implant exposure. You can use the bone grafts in ridge site, ridge splitting technique. You notice there's a very thin ridge over here. You split the ridge with vertical cuts, and you augment that space in between with particulate bone graft material. And 5 weeks post-operatively, you have got good implant site development. You can use it in sinus augmentation. So you have lifted the sinus membrane through the lateral window technique and place the particulate graft, allograft, or the autograft in the area below the sinus membrane, such that you increase the height available for implant bone. You can use your bone graft in socket preservation also after an extraction if you want to preserve the socket, or you can use it in immediate implant placement also to bridge the gap between the implant and the tooth socket. You can use it in the tent pole technique for increasing the height of the bone in the mandible, as well as in the bone ring technique using trephines for implants and a ridge split. So we'll look at the video now. And you see, this is a combination of a ridge split. The video may come a little bit jerky, but I'll try to run you through it. And there is a very thin ridge out here. And through the initial template, the holes have been made. And you see that a little bit of cancellous bone, autograft bone has got collected, and xenograftic bone is being placed into the socket. And then further drilling will take place. We are anticipating that there will be, you see, he's collected the autogenous bone, and he will now collect it into the surgical dapon. And we will place the pelling pin to see, and the periosteal releasing incision is being given to see that you get good primary closure. The implants are being placed, but yet the chances of fenestration and descents on the buccal side are very high. In fact, the other implant has already descent penetrated through the buccal window. And so it requires buccal bone augmentation. And this buccal bone augmentation can be performed in a sandwich technique by using the autogenous bone and then using the xenograft. Remember, we are not going to load these implants immediately, and the implants have been tightened and torqued. And the excess saline is being removed very carefully. And you see a lot of autogenous bone has got collected. And that autogenous bone is placed first. It is not mixed with anything, remember. And after this, the actual xenograft is being placed on the top. So this xenograft is placed as a sandwich on the top over the autogenous bone. And a little bit of overfilling we did because we were scared of the dehiscence. And we placed the collagen membrane and tried to get primary closure. Primary closure, remember, is very, very important. Stabilization and fixation of that area is very, very important. And you got a nice tight closure using vicryl sutures. And that's how we carry on. So what are the failures? How do we jump from failure to success? Remember, I talked about plaque control, patient selection, root preparation, adequate wound closure, complete soft tissue approximation, periodontal maintenance, and your knowledge about your graft material. If you look at the World Workshop in Periodontics, they said you must be able to select the appropriate surgical technique and the importance of the tooth in the overall restorative treatment plan, and the patient selection is very, very important. What are the future directions? Tissue engineering with respect to the signaling molecules, where that is your bone morphogenetic proteins, the bone grafts and the cells, as well as the incorporation of growth factors in our graft, maybe a gene-based therapeutics to get a biocompatible scaffold, maybe an RNA-based therapeutics wherein expression of certain genes which are detrimental, which are blocking the tissue regeneration process, can be silenced by RNA interference. Maybe even three-dimensional printing as per the defect site to get a bone substituted block, osteodensification, but that's a whole totally different chapter, and bone substitute materials made out of autogenous dentin matrix. So in conclusion, after this long webinar, we can conclude that periodontal regeneration is definitely a clinical possibility. The clinician must carefully evaluate the various regenerative and reparative approaches and decide which technique may result in the best clinical outcome. You may include the barrier membranes of GTR or the biologic modifiers like bone morphogenetic proteins. The form has been sent to you all by now. Please answer the post-webinar form. Remember, heroic or herodontics should be deferred. Be smart, be know your materials, follow the basics. Stay safe, please. Stay healthy, please. Stay happy always.
Wonderful lecture, sir. Very well covered the bone and the bone graft material from basic to advanced. How to harvest the bone graft, which instrument should we use to harvest the bone graft, how to handle the bone graft material. I am sure your lecture definitely benefited to all postgraduates. And I think there is no questions in the chat box because you have nicely presented minute details about the bone and the bone graft material, sir.
Thank you, madam. Thank you.
Over to Dhawal.
Thank you, sir, for a very basic and informative lecture about bone grafts. I thank you, our moderator, Dr. Surekha Rathod, madam, for her valuable time. And I request all the participants to fill up the post-webinar link. I have posted the link in the group. So thank you, sir. Thank you, ma'am.
Thank you, Dhawal.
Any questions or queries, or students want to see the instruments again? Because earlier I believe they could not see properly. I do not know. It's up to them. Up to moderator, madam.
Dhawal.
1 minute. Sir, the queries will be posted in the group, so I will let you know.
Yes, yes.
Okay, so thank you once again, all the participants. I'm ending the session now.
Yeah, thank you very much, Dr. Dawal.
Thank you,
Thank
sir.
you,
Have a
sir.
nice day. Stay safe.
Thank you.